and even before the diagnosis. So we're going to trace the natural history of type 2 from insulin resistance to the clinical diagnosis. And we will review the evidence base for beta cell dysfunction, which already present at diagnosis, including the functional study, which the pathophysiology process. Also, we're going to examine the evidence for the progressive nature of type 2 despite the treatment. So it doesn't stop only before we make the diagnosis. Even after we made the diagnosis, all of us know the progressive nature of the disease. And we want to go through the burden of beta cell dysfunction and the vascular risk, whether it's already present at the diagnosis. We will relate the microvascular and macrovascular complication to the time of the diagnosis. Is that at the diagnosis, it's before, and we will see what are the drivers for that. We're going to identify the baseline assessment that cannot be deferred. After I introduce how early it is and the strategy for the right time diagnosis. Those are probably all of us knows this, but through my presentation, I'll try to dissect those figures and show you the evidence for those figures. So when we talk about by the time we make the diagnosis, how much has already been lost? And that's a very common question, and we always debate the years or the number of years when the diabetes started or when the pathophysiological process started. So the famous statement is 50% of beta cell function is already lost at the moment of the diagnosis, and the estimated duration of hyperglycemia before clinical diagnosis ranging between 4 to 12 years, depending upon the evidence you look for. And that's quite important. That's 1 in 3 newly diagnosed patients already show microvascular complication. I might show you some slides which you already have seen, but I'll give you my view of those slides, okay, and the interpretation. So we agree that the prevalence of diabetes is high, and we agree it's growing up globally and it's became burden. So all of us agree about. My talk tonight will be mainly it's type 2 diabetes because it's account for 90 to 95% of all diabetes cases. And that will be the case, I think, for the other presentation as well. The other important thing is as the number of population globally grow, but if you look at the number of people with diabetes, is projected to grow more than twice as fast as the global population itself. So the prevalence is not go with that when the number of population grow, but it's twice as that growth. So that's quite serious. When we talk about diabetes, we say every one person with diabetes, there is another one undiagnosed. But let us look at this carefully. So if I go back to 2013, and you look at the patient who they are undiagnosed with type 2 diabetes, it's 45.8 in 2013. And by 2021, the number come down slightly to 44.7%. I'm talking about the undiagnosed patient with diabetes. But in year 2024 and 25, the IDF estimate 42.8% of the adults with diabetes globally are undiagnosed. So what those figures showed, basically, there is reduction of the people who they are undiagnosed. So maybe there is slight improvement in detection of the cases and the screening, which I'll come to it at the end of the presentation. But what we understand from this and what's this reflect basically is those who they are undiagnosed, what does it mean? Means delayed treatment initiation and extended period of unrecognized hyperglycemia, and that, of course, with the vascular injury. The more years without diagnosis, more exposure to the high blood sugar, more vascular injury. And we have to ask ourselves question, why is that? what are the gaps? Those gaps are driven by low awareness, and I think Mohab now doing a great job when it comes to raise the awareness about the chronic diseases, and on top of them is diabetes and obesity. Also, the underuse of health services. So we don't, as we are having inertia when it comes to the treatment, it's the same thing when it comes to the diagnosis. And if you look all over the world, there is a limited screening capacity. So this is in brief the gaps we should improve, and we try to fill up to be able to reduce the number of those without who they are undiagnosed. So the time lag is very, very important, and we learn a lot from the retrospective retinopathy-based modeling and population glucose tolerance studies, both placed through disease onset years ahead of the clinical diagnosis dates. And we know that even when it comes to the A1C and making the diagnosis and take the A1C as the test to use, it came from the retinopathy study. And the other important thing is that the real world delayed diagnosis rate range between 23 to 74 across the health system, driven by the three different sectors. It's either the patient, they don't present themselves, or they don't take the advice to go and check their blood sugar, physician, and the system level clinical inertia. We know not many countries have screening programs. But what we have to keep in mind, and that's why in red, every undiagnosed year is a year of unmeasured and unmanaged glycemia and vascular exposure. So this is how we should look at it. It's not only that the patient after 1 year will be started treating, and I'll tell you through my presentation that the exposure, its recent exposure to glycemia is even more driver when it comes to the vascular energy. So let me take you through the dark, the silent phase that most of patients, they don't know what's going on, and us as healthcare professional. So now we know 8 to 12 years, what happened in those years. So normally, if you start at the beginning here, normal glucose tolerance, that's the normal subject. Then the insulin resistance start, but what happened for the healthy pancreas start to compensate. So the secretory capacity of the pancreas increase. So that will put lots of loads on the beta cell function, and the beta cell function will start to decline. And what after that? The stage of the prediabetes, whether it's impaired fasting glucose or impaired glucose tolerance, then after all those stages, the clinical diagnosis become aberrant and the type 2 got diagnosed. It doesn't stop here, by the way, and this is what I mentioned in the previous slide. So even after diagnosis, it's a progressive process when it comes to the beta cell failure and the complication. It doesn't stop at all. So it's like continuous process, and that's why the beta cell, whether it's the secretory capacity or the mass, got reduced. So, and what we have to keep in mind, which you will listen about in the last lecture, the vascular energy from injury from the hyperglycemia, dyslipidemia, and hypertension can accumulate through the silent phase. You don't know the other, they are present as well. And if you look at the figures, those three things, they more than often coexist together in the silent phase. And that's long before any diagnostic code is entered. And that's quite important to keep in mind. So what's the defect drive the hyperglycemia? There are two conversions. One, the insulin resistant, so the site of the action become difficult and need more insulin quantity to overcome the resistance, reduce the action in the liver, skeletal muscle, and the adipose tissue. More than often, present years before the diagnosis and linked to obesity and visceral adiposity. Those are the one which drive the insulin resistance high and the inflammation on the same time. So that got compensated by the pancreas, so hyperinsulinemia, and that put more demand on the beta cell. So now the site of the action need more insulin, and that's put strain on the beta cell, and beta cell dysfunction become progressive loss of secretory capacity and the mass itself. And the rate limiting step is the ultimately decision for progression to overt hyperglycemia. And all of us know more glucose, more toxicity to the beta cell. And this is what we do with our students in the lab with the beta cell line. When we put increased glucose concentration, we see the beta cell die quicker. And they continues to decline even after treatment is started, the central theme of this talk or of this module tonight. Now let us talk about the direct evidence, which is mainly the functional study to quantify the beta cell loss and around either before or around the diagnosis. And all of you know it's not easy to study the beta cell because most of it is a function and direct study, because it's very difficult to do the histopathological and structural study because you need to take the pancreas out. But I'll go back to the first figure I have shown you, which is the 50% reduction in HOMA. That came from the UKBDS. You know, UKBDS, they use the HOMA-B to estimate the beta cell, function for those who they are a newly diagnosed patient. They're not being diabetic for a long time. And the function already being reduced by 50% relative to the normal at the moment of diabetes was clinically diagnosed. So that's quite important, and that's one of the first piece of the evidence we have. We know HOMA-B is not that sensitive, but if you go further and look at the more sensitive dynamic testing, what does that mean? That you stimulate, so you put more pressure on the organ, and here the cell is the beta cell, and you see the through functional deficit is even greater than those evidence we had from the HOMA modeling suggest before. And this implied beta cell decline was already well under way, likely for roughly a decade, as we have got from the UKBDS evidence. So that's another evidence when it comes to the beta cell decline. This is a more recent cohorts study which talk about the beta cell decline between year 20 and 23. Let me take you through GRADE, which is published in Diabetes Care in 2024, and it's include 5,047 patients. And this is head-to-head randomized controlled trial. What they have done, basically, the background therapy is metformin, and they add 4 different anti-diabetic medication: insulin glargine, glimepiride, liraglutide, sitagliptin, and what they found is that the beta cell function progressively decline over 5 years in every treatment arm. It doesn't matter whether the patient on the insulin, whether they are on the glimepiride or liraglutide or sitagliptin. So this is what I have alluded to in my first slide or second slide, that the progressive decline of the beta cell, even when they are on the treatment, and this study showed us, doesn't matter what the treatment is, there is decline in the beta cell function. And the other important thing from the finding of this study is that the lower baseline beta cell function, it's independently predict the earlier glycemic failure in GRADE study. So reverse at the diagnosis dictate how long any regimen lasts. And that's important because the earlier you make the diagnosis, the more reserve beta cell mass or function is there. So that's the other thing is that's a nice review published in Diabetologia 2025. There is and they look at the stress factors or markers, And those stress markers track the decline in insulin secretion before diabetes even develop. And we're doing some of those study right now as a prediction for the patient who they might develop GDM, and also as a predictors for the complication in my lab. The other Korean data came from the Korean cohort study in 2024. The glycemic exposure, recent glycemic exposure more than diabetes duration or drug time. So the exposure, recent exposure, that's mean high glycemia or hyperglycemia, it's more important in comparison to the diabetes duration or drug type. Not only, okay, that's the mean dominant factor, but in comparison to those, it's more dominant driver for a measured beta cell function. The other important thing, if you look at the Belfast diet study on the left-hand side, there are two phases. So there is initial phase, which might be the pre-decline, it's slow, but the rapid decline phase coming later, and that's because the high blood sugar and the exposure is more longer. Now we're coming to the autopsy studies, which confirm the loss of beta cell mass. Butler and his group, back in 2003, they examined 124 autopsy pancreata, and what they looked at, they compared the people with type 2 diabetes with impaired fasting glucose and matched with non-diabetic control. Beta cell volume was reduced by 41% in lean, and 63 in those who they are obese with type 2 diabetes in comparison to the non-diabetic controls. And that's quite a huge difference between the two, as you can see on the left-hand side. The other thing, we talk about apoptosis for lots of cells, and that's the process which happened for the cell as programmed cell death. But with beta cell, apoptosis was increased 3-folds in obese and 10-folds in lean patients with type 2 diabetes. So look at the obese and look at the lean patients who they have diabetes. It's much, much higher. And the last thing from this is that the direct histological proof of beta cell mass not only function is substantially depleted by time diabetes is diagnosed. So it's not only it's also the mass itself. Now talking about the deficit is present. And this is again from the same study done. But what's the other thing is that the people with impaired fasting glucose, pre-diabetes, so there's no diabetes yet, they already showed 40% of beta cell volume deficit relative to the obese and non-obese reference. And the figures explain that very nicely. Non-diabetic obese individual physiologically expand the beta cell mass. So there is, if you look at the mass, it's expanded, and that's to compensate for the insulin resistance. The independent autopsy and surgical resection series report beta cell mass reduction in range of 30 to 63% of those with type 2 diabetes. And I don't have to talk more about the structural lesion with those with type 2 when the diagnosis is not made. So they reserve fall with the duration. And if you look at the duration here, 0 to 3 years duration and 16 to 18 years, you can see the difference and the secretory ability or capability of beta cell, it's declined quite a lot. And again, this data supported by many studies, and especially the UK BDS group. What you see in those, so you see the decline is there, and that's why after you stop the treatment, the A1C on those two groups and the UK BDS, they come exactly the same. So what about the beta cell reserve I mentioned earlier, which might predict the treatment durability? The lower patient beta cell reserve at the treatment initiation when we start the treatment is the sooner monotherapy fail. And we'll talk about this in a moment in the second talk. So lower reserve, that's mean monotherapy, probably it will not work, and probably dual therapy is needed. And the direct clinical consequence of how much function has already been lost at the diagnosis. And in grade, you have seen that in grade. So regardless what the treatment is, there is progressive failure of the beta cell. The strong rationale for assessment of the disease severity, not just the glucose level at the point of the diagnosis. That's very, very important, because not every diagnosis done on the time, and the beta cell function varies between the patient. So the point regarding after we're making the diagnosis and start the treatment with the progression stop, we say the progressive nature of the disease doesn't make that process to stop. And if you see the 9-year UK BDS, okay, a group, only 25 intensively treated patients still achieved A1C below 7. What does that mean? On the immunotherapy, that means there is a progression. And that's got supported by the HOMA modeling, which reflect the ongoing process of the decline of the beta cell, which I showed you earlier. So that's quite important when you decide whether it's a monotherapy or dual therapy. The UK BDS legacy effect, what does that mean? That's mean the complication or the outcome when it comes to the cardiovascular disease, it's less 10 years later. So when you do, for example, in this study, when you do like 1-year control, so there is difference between the A1C on the treatment group, the intensive group, in comparison to those who they are on standard care. After a year, the A1C become exactly the same. But when they follow 17 years later, those patients, the complication outcome is completely different. It's much better in those with the intensive control early. And that's what you call the legacy effect and the metabolic memory. And this is what we want to do when we decide what treatment we should start, whether it's monotherapy, dual therapy, or making the diagnosis early. The last thing I want to talk about is the complication, and already presence of ask you yes or no, everybody will say yes, because this is what we do as a screening when we diagnose somebody with type 2 diabetes. So we talked about the glycemic exposure, and if you talk about complication, micro and macro vascular complication, both of them, they developed in proportion to the duration and severity of glycemia and the cardiometabolic exposure, which they coexist early. Now, I think all of us know this, but the important question, can we quantify the burden of those complications before the diagnosis or during the phase of the silent phase or at the diagnosis time? So let us answer this question by looking at the retinopathy, nephropathy, neuropathy, and the macrovascular complication risk factor already measurable at the diagnosis. Of course, we have to start with the retinopathy. This is where the most of the evidence is. And you can see the difference, either surveys or study, and you look at the prevalence at the diagnosis. So now somebody come and today we made the diagnosis of type 2 diabetes. Look at the prevalence of the retinopathy at the time of the diagnosis. It's from 12, 17, 19, and 19, and 37. And if you look at the first one, UK BDS, then the UK Primary Care, Scotland, Sweden registry, which is one of the famous, and that's quite recent, is 2024. And Sweden, they have more than 109 registry, and one of them is diabetes, and there are lots of data from those registry. The low and middle income country meta-analysis, again, it showed evidence of the retinopathy at the diagnosis. So at the diagnosis, okay, not only that you find retinopathy, it's even predict further progression. So for example, 37 of UK patients already had retinopathy at the time of the diagnosis. 29% of those with retinopathy at the diagnosis progressed more than 2 steps within 6 years. And 22 of those with no retinopathy at diagnosis developed at 6 years. So that at least give you clue to how frequent you should investigate and follow up those patients. Nephropathy, so 7% of people with type 2 already have the microalbuminuria at the time of the diagnosis. And also the recent data in 2022 published in a nice systemic review for the low middle income country, and they found the microalbuminuria 10 to 50% of the cohort and the macroalbuminuria 1 to 24% across 33 studies being included in this meta-analysis. So without intervention, so if you don't intervene, and if you don't look for it and you don't find it, that microalbuminuria prevalence to 25 by 10 years post-diagnosis. So what's the importance of this and how we should reflect on this? Because early nephropathy is asymptomatic, so very strong message we have to look for it actively by doing the ACR and the GFR. That's very, very important. Neuropathy, more or less the same with this percentage, but people, they think we might not have a patient have neuropathy at the diagnosis, but you can see the prevalence here. And more importantly, neuropathy is more than often it got forgotten when it comes to the screening time. Peripheral neuropathy has also been documented in adults with undiagnosed diabetes. So those who they don't have diabetes, they come with the symptoms. When you investigate them, you find the injuries already been there and patient, they have diabetes. So neuropathy is frequently asymptomatic in the early stage and is missed unless a structural foot and nerve examination done. Macrovascular risk is already established at the diagnosis. Those are the evidence, whether it's ischemic heart disease or peripheral arterial disease. Now, that's the cardio risk cluster. That's very, very important. So insulin resistance will not appear on its own. The other drivers, the hyperglycemia, dyslipidemia, and hypertension, they've been there for some time. And this is how the inflammatory process gets driven. This is the key reason cardiovascular risk assessment must be part of the baseline work up of the diagnosis, not deferred until glycemic control is achieved. That's one of the strong messages I would like to get through to you tonight. So to answer the question, why is it already too late? Beta cell, 50% plus at the diagnosis, decline for 10 years beforehand. Beta cell mass, 41 to 63 deficit on autopsy versus the matched control. Retinopathy, 12 to 30% already present at the diagnosis by setting. Nephropathy is 7 to 15% microalbuminuria already present at diagnosis. And in neuropathy, median 16% already present at the diagnosis. Macrovascular risk, cardiovascular risk factor and disease already established in the screen detected cohort. So the answer, yes, it is too late. The time we are making the diagnosis. So to close the gap, right time of the diagnosis, what we should do, and I think this is why this learning objective being put on. So the earlier detection changed outcome. We have evidence for that. We have the addition Europe, which demonstrate that population screening for type 2 primary care is visible and identify patient with high burden of modifiable cardiovascular risk factor at the point of detection before the symptom would otherwise have prompted the diagnosis. The stimulation modeling on addition Europe cohort estimated that even 3 to 6 years delay in the diagnosis. So with that, of course, increase the model cardiovascular morbidity and mortality. UK BDS have seen the evidence, not only the glycemic, but also the cardiovascular and mortality benefit if you do early prevention. Together, these findings support both screening to detect diabetes earlier and early intense multifactorial management once it is found. So that's what the evidence tells us. I put this slide. I know my colleagues, and because I attended the last module, they took very details. And this is who and when to screen. That's the UAEDS guidelines, which we have published recently. So I would like you to go through this every time you see somebody which they fit this criteria, that you go for the screening. So you know the age, and you know the even for the children, and also anyone with normal results, what you should do, and the pre-diabetes, whether it's impaired fasting or impaired glucose tolerance, what the next step is. Now, the baseline assessment that cannot be deferred, and I mentioned that in my presentation. From what I have told you, that's why you have to do the A1C to confirm the diagnosis and to establish the baseline glycemic burden. You have to do the lipid profile because of what I have told you, that the dyslipidemia coexists, and it's again in the silent phase. You have to do dilated retinal photography screening. We showed you the retinopathy present at the diagnosis. Weight is a fundamental issue, and I think there will be one module just dealing with the weight. Renal function, it's a silent, we have to look for it. Blood pressure, it's one of the cardiovascular risk factor, and it's coexist. Foot and a neuropathy examination need to be done. And of course, the cardiovascular risk assessment, which will be done by my colleague, Prof. Mohammed Hassani. So the last slide, and what I would like you to take with you tonight from this presentation, is beta cell function is already reduced by 50%. And it's not only figure. I showed you the evidence and where this figure came from. And beta cell mass by 41 to 63 at the moment type 2 diabetes is diagnosed. The disease process, insulin resistance, beta cell decline, and vascular injury began early, often a decade before the clinical diagnosis. A meaningful proportion of newly diagnosed patients already have microvascular or macrovascular complication. Type 2 diabetes is progressive. Without intervention, beta cell function continue to decline, regardless of the therapy. And I'm sure Dr. Ala and Dr. Lamin will come back to this point, patients on treatment and the deterioration of the control. Early intensive control produced durable legacy benefit, delayed the diagnosis years for achieving the benefits we need, and thus the metabolic adaptation. Risk-based screening must be systematic, and defined set of baseline assessment must be performed at the diagnosis and not deferred. Please. With that, I'll stop here and thank you very much.
Thank you very much, Dr. Salah, for the excellent presentation. Now it is my pleasure to welcome Dr. Ala Al-Bashir. Dr. Ala is a consultant endocrinologist, Dubai Hospital, clinical professor of endocrinology, Mohammed bin Rashid University, recognized researcher with extensive publication and contributions to regional and international guidelines. Dr. Ala, the floor is yours.
Thank you very much, Dr. Farghari, for the nice introduction. Dr. Salah has made my talk very easy. He definitely convinced me and you that diabetes is a progressive disease, and it's already too late when we diagnose a patient with type 2 diabetes. So our next job is to try to treat those patients as early as possible. And I'm supposed to convince you that a tight glycemic control early on is beneficial and a delay in tight glycemic control might be detrimental to our patients. And for this talk, I don't have any conflict of interest. So my presentation is very simple, and it goes this way. I think we're very blessed, alhamdulillah, that we lived in an era where we have the variety of weapons to treat, an arsenal to treat our patients with diabetes. Early on, and at the time, maybe in 1998, when at the time of the UKPDS study, we wanted at that time to establish that a glycemic control is good. So until 1998, we were not actually very sure. We just reduced the blood sugar, and we're not sure whether we're going to get benefits. And the first evidence that we had that glycemic control is essential was from the UKPDS and the ACCORD trial for patients with, and the DCCT trial for patients with type 1 diabetes. Fortunately enough, that successful step has led to other steps. And the next step from the study itself was establishing the legacy effect that a good glycemic control early on will result in a durable and metabolic memory. But then we started to treat patients who were newly diagnosed and lately, who has been having diabetes for a long time and had what we call already complications, cardiovascular risk. And then when we implemented that in other studies like ACCORD and VADT, we didn't see much benefits. And then the next step came is, okay, now we understand we have to go for a tight glycemic control. So let's start early on with a combination therapy, and that's the VERIFY study, which showed beautiful results. And then we got convinced that reducing cardiovascular risk doesn't come only with glycemic control, and there should be a multifactorial intervention. And this is basically the evidence arc for the management of diabetes with early intensification. How did we go through these studies? I'm going to explain it in details, and I'm not going to take a long time. So we started with the cornerstone study, which is the UKPDS study in 1998. And the UKPDS, there were multiple studies came out of the UKPDS. The UKPDS 33, which was published in 1998, has shown that intensive glycemic control, that means an A1C of 7 versus 7.9 or 8% in a newly diagnosed, and this is an important word, in a newly diagnosed type 2 diabetes, has resulted in 25% reduction of any microvascular endpoint. That was very significant, but we didn't have any evidence of macrovascular complications. And a sub-analysis, which is the UKPDS 34, in the same year has shown that metformin in overweight subjects has reduced all-cause mortality. All-cause mortality, and I want you to focus. It did reduce the all-cause mortality, and that cemented metformin as a first-line therapy from that time until 2015, until 2020, which now people has moved from metformin to other lines. So a subgroup of patients did benefit with regard to mortality, and those were the patients who are obese and on metformin. So that was the cornerstone. So we understood that a good glycemic control early on in newly diagnosed patients with diabetes and a good glycemic control is 7%. So what happened after the study finished? So after the study is over, then they just followed patients for another 10 years. And after 10 years, what they found that the A1C is almost equal between the two groups. However, in the post-trial monitoring, that was 1998, in 2008, they looked at patients with an early glycemic, with intensive glycemic control early on. And what they found, that they still carried on the benefits of early glycemic control, where we did see almost 24% reduction in microvascular disease, and it was 25 previously. We have seen 13% reduction in death from any cause, as well as 15% reduction in myocardial infarction and 33% reduction in the metformin subgroup, which earlier showed a benefit. Now the benefit is even better, 33% reduction in this subgroup. And if you look here at the curves on the right side, this is 10 years post trial. You could see 13% reduction in all-cause mortality and 15% reduction in myocardial infarction. And you could see a very nicely separated lines with regard to all-cause mortality. So now we did understand early glycemic control in newly diagnosed patients with diabetes is really beneficial, and it gives you a legacy effect. But what happened after that? We thought, let's implement the same in patients with established cardiovascular disease or high cardiovascular risks, and that was the ACCORD trial. It's the action to control cardiovascular risk in diabetes. It's a randomized controlled trial, and the aim here was to bring down the A1C to less than 6 versus the standard of 7 to 7.9. The study has included almost 10,251 patients with type 2 diabetes, and as I mentioned, they were patients with established cardiovascular disease and high cardiovascular risk. The achieved glycemic control, not 6, it was 6.4 versus 7.5. And what was the result? We actually stopped the study very early because of quite obvious harm. The hazard ratios for mortality were 1.22. What does that mean? It increases the mortality by 22% in patients with tight glycemic control. And if you look at all-cause mortality here, the red line are patients with intensive glycemic control in the ACCORD trial, and the interrupted blue line are the standard therapy, which is 7 to 7.5. And if you see that the all-cause mortality is definitely higher in the intensive group. So we got to know that intensive glycemic control late in someone with established cardiovascular disease and a longer duration of diabetes might not be helpful. But we did not stop there. We actually went for another study in between 2009 and 2015, which is the Veterans Affairs study, which looked at advanced disease in patients, the Veterans Affairs diabetes trial. It's a randomized controlled trial that included almost 1,700 veterans who are poorly controlled with a mean duration of 11.5 years, more than 10 years. And I want you to look at this point specifically, more than 10 years. Why is it essential? If you look at risk stratification, even in UAE guidelines, we put a cutoff 10 years and more as very high risk patient. So it's included in the risk calculator. Diabetes more than 10 years plus other factors might put you at a very high risk or high risk, depending on associated risk factors. So in this study, what we achieved is 6.9 versus 8.4. It's not even 6.5, it's 6.9. And what we found that there are no benefits at all. The results out of this study were basically neutral with regard to mortality in patients with type 2 diabetes. You could see a 0.88. This is the hazard ratio. It ranged between 0.74 to 1.05, and that was not statistically significant. So there is no primary cardiovascular composite. That was in the trial. But when we followed those group of patients for almost 9 to 10 years, what we found that the primary cardiovascular composite has just been significant, with the p-value is 0.04, and the upper limit of the hazard, the confidence interval is 0.99. So following patients with tight glycemic control for more than 10 years to achieve some benefit. Now, the all-cause mortality was not definitely significant in this study. So if we look at the studies that looked at intensive versus standard glycemic control, the UKPDS was the only one that has shown much benefit early on and at 10 years of follow-up. And that says early control wins over very late after 10 years glycemic control. The other two studies, the Accord actually has shown harm, increased risk of death because of intensive glycemic control, and in patients with established cardiovascular disease. In the VADT study, the results were neutral. It's a 10-year, almost 10-year, and the glycemic control wasn't really very tight. It was 6.9%. So this is what we got from these three studies. If we look at the forest plot for these studies, if we look at the primary composite outcomes, in UKPDS it was positive. In the other studies, it wasn't really positive. But overall, you would see a tendency in all the studies with intensive glycemic control towards benefit rather than harm. But if you look at mortality was significantly higher in patients with established cardiovascular disease. So early on in newly diagnosed patients, you are going to get much of benefit. Now, the forest plot for micro and renal outcomes is always significant with intensive glycemic control. If you look at all the studies, not only the ones I mentioned here, the UKPDS or advanced or stenonephropathy or stenoretinopathy or stenoneuropathy, you would see a significant benefit in microvascular, but you don't get macrovascular benefits in late intensification. So what is the next step that we took? So we thought, well, good glycemic control and intensive glycemic control early on results in macrovascular benefits, as well as a good metabolic memory and a legacy effect. So what we did is we started patients newly diagnosed with type 2 diabetes on a combination therapy of metformin and vildagliptin. And we tried to look at the early combination. How are we going, and for how long are we going to maintain an A1C at target? And if you see at the dotted line where we started only metformin as per guidelines at that time, and the early combination of metformin vildagliptin, the combination win because it gave a durable benefit. If you look, the time to initial failure was significantly lower, higher in combination therapy compared to metformin alone. So this is a concept that tells us we should not delay the management and intensive control. So this is a study against clinical inertia where early metformin and vildagliptin, when compared to metformin alone in newly diagnosed type 2 diabetes patients, halved the risk of glycemic failure, and it has increased the duration and durability of treatment. So we took it also another step further, and we found that yes, early intensive glycemic control results in microvascular complications, and it results in as well cardiovascular benefits, but it takes a bit longer of time to get the benefits, the macrovascular complications. So we thought, why don't we interfere in a multifactorial way, where we treat the dyslipidemia, we treat the hypertension, we get a good glycemic control, and we see whether we're going to get benefits or not with regard to mortality and cardiovascular benefits. So this is the STENO2 study, which is an intensive multifactorial intervention. It's a randomized controlled trial where we targeted glucose, blood pressure, lipids, plus antiplatelets and conventional versus conventional care. And they looked at 160 patients with type 2 diabetes and microalbuminuria who already have an established nephropathy or diabetic kidney disease. The duration of follow-up was initially 7 years, 7 to 8 years, but it was extended up to 21 years. And we could see even in the follow-up studies after 21 years, a sustained reduction in cardiovascular events, in nephropathy, in mortality over time. And the benefits in mortality actually were smaller, but as we go with time, the benefits in mortality has widened and became more obvious and clear. So the mortality hazard ratios has been reduced by, mortality has been reduced by almost 45%. The hazard ratios were 0.55, and that has gave people an extra 8 years in their life expectancy. If you look on the right side, where you see the overall survival in a STENI-2 study, as I mentioned, the hazard ratios were 0.55, and those with intensive glycemic control, their survival was much, much higher compared to the interrupted line where they had a conventional treatment. So these were the randomized control trials. And if we look at meta-analysis that has been conducted with this regard to intensive glycemic control, there was a meta-analysis by Turnbull in 2009, where they looked at 2,700 patients pooled across different studies, the ACCORD, the ADVANCE, the BADT, and it showed that each 0.9, not only 1%, 0.9% reduction has produced 9% fewer major cardiovascular events, driven by basically a reduction in myocardial infarction, but no impact on mortality. And another meta-analysis by Ray et al. That was published in 2009, it showed that intensive glycemic control reduces non-fatal myocardial infarction and coronary heart disease events without increasing the overall mortality. So intensive glycemic control, you might not get an increase in mortality. And I will add, in early or newly diagnosed patients with type 2 diabetes. Another meta-analysis by Zongas in 2017 reaffirmed the robust microvascular benefits and the modest macrovascular effect of intensive glycemic control, making it part of a multifactorial intervention rather than focusing only on glycemic control. So this is the evidence. I just pulled the evidence from different randomized control trials as well as meta-analyses. So what's the conclusion out of this? That glycemic control improves microvascular complications more than macrovascular complications, and very tight late control might result in harm. It might be even maybe harmful than beneficial later on. So we need to treat our patients early, we need to treat them to target, and we need to treat them comprehensively. And there is a timing for everything. Early on gives you the legacy effect and reduces the complications later on. And we need to know the ceiling which patient we should intensively control and which one we should keep the glycemic control at a bit loose compared to other patients. And giving a combination early on reduces the inertia, gives and prolongs the time to treatment failure. Now, one last thing, I'll put it as a conclusion, and it's a story. It's a Greek mythology that about Daedalus. Daedalus is a craftsman who worked for a king, and the king name is Minos. The king got angry with him, and he exiled him in one island because he helped the king's enemy. So while Daedalus was in the island, he was exiled, he and his son, in an island where he cannot take a boat, where he cannot swim because the land is very far. So being a craftsman, he spoke to his son and he told him, let's make wings that try to fly to the land. And he fashioned 2 pairs of wings out of wax and feather for him and for his son. And he tried his wings first, and then he talked to his son, told him to go out of the island, and he warned him, son, don't fly too close to the sun, and don't go too close to the sea, and follow my path while we fly. So they flew out of the island, but the son was quite excited, and he flew quite close to the sun. What happened? The wax melted, and he actually fell down in the sea, and he sank in the sea. He sank in the sea. He fell into the sea in an area which bears his name right now. It's called the Icarian Sea. It's near the island of Icaria. The moral of this trial, of this story, is basically we have to be very cautious with our patients. We shouldn't be very ambitious and intensively treat them and cause hypoglycemia and result in harm. But at the same time, we should not be very loose and let the glycemic control go very high and results in complications. And with that, I thank you very much.
Thank you very much, Dr. Ala, for the excellent presentation. I encourage everybody to write their questions, please, so we can have a very informative panel discussion. Now it is my great pleasure to present Dr. Al-Amin. He's a consultant endocrinologist at Dubai Hospital and Associate Professor of Endocrinology, Mohammed bin Rashid University of Medicine and Health Science, Fellow of the Royal College of Physicians, UK, the American College of Physicians, and the American College of Endocrinology. Pre-diabetes and the early type 2 diabetes. How intensive should we manage? Dr. Al-Amin, the floor is yours.
Thank you very much, Professor Farghali, for the kind introduction, and thanks to the organizers for inviting me to this important series of educational conversation regarding diabetes in general and its complications. My role today is to cover the pre-diabetes and early type 2 diabetes. How intensive should we deal with them? And without any further ado, this is my disclosures. And we are in a very particular and unique media or environment where we all know that the prevalence of both diabetes and pre-diabetes are almost 20% of the total population. So this leaves us with almost 40% of the total population in the area where we do practice in are living with either pre-diabetes or diabetes. Furthermore, and this has been discussed quite extensively in the previous two talks, that the diabetes and pre-diabetes are strongly associated with cardiovascular disease. And more importantly, the mean cutoff or mean age of having mortality related to cardiovascular insult in the UAE or the Gulf region in general is 10 years younger than the international cutoffs. So the international mean age is around 55 years of age, and here it's around 45 years of age. And this includes also most of the Southeast Asian geographical area. So this leaves us with a very unique community that we need to be quite careful when we deal about metabolic disorders and concomitant cardiovascular disease. Professor Salah, Professor Ala have alluded to the early intervention in all the paradigm of dysglycemia. I'll just concur that the information that when we deal with pre-diabetes, it's the fasting plasma glucose between 100 and 125 milligrams per deciliter, and the postprandial hyperglycemia of 140 and just less than 200, and an HbA1c between 5.7 and 6.4. So we shouldn't deal with this as a waiting room. And we deal with the person living in the pre-diabetes phase that we are just waiting for the dysglycemia to progress and have an over type 2 diabetes in order to be aggressive in dealing with that. This is an area where we may consider it as an area with established disease. Professor Salah have alluded to the remarkable decline of beta cell function after diagnosis of type 2 diabetes. But he also mentioned that at the time of diagnosis, an average of 40 to 50% of the beta cell mass might have gone already. So the decline has started a couple of years ago. And why do we need to wait all this period until we get the time of diagnosis in order to guard against the further decline? So lots of work needs to be done at this phase to prevent this initial decline and, of course, further decline after diagnosis of type 2 diabetes if it took place. We need to agree by the end of this talk that prediabetes is not a mild dysglycemia. It's a potential multi-system disease. And this has been described in so many longitudinal studies where in early phase of dysglycemia, moving from the normal glycemia to prediabetes, yes, the insulin resistance increased, the beta cell function, we have a marginal increase and then decline. But the micro and macrovascular complications starts here. So we shouldn't deal with this phase as just hyperglycemia, mild hyperglycemia. It's an area where, or a phase where we do have an established micro and macrovascular complications. So it's not a waiting room for the dysglycemia to progress and the cardiovascular or cardiorenal insult to take place. It might have taken place already. And this has been also described earlier in the earlier talks. I'll just summarize them that in the prediabetes, we have almost 20% higher risk of cardiovascular disease in the phase of type 2 of prediabetes. And when the dysglycemia progresses and the patient having an established type 2 diabetes, the risk of cardiovascular insult cumulatively is almost double. But 20% higher risk of cardiovascular disease at the phase of prediabetes. 17% of people living with prediabetes are having an established chronic kidney disease already. And almost a third of patients with long-standing type 2 diabetes are living with that. So it's not even the 50% of the established long-standing type 2 diabetes. It's more than that. So it's, again, not a mild dysglycemia. It's a cardiorenal insult phase. Peripheral neuropathy, it's the highest rate during the prediabetes and early type 2 diabetes, and this is always overlooked and not well taken care of. Okay, so we have a problem and we need to guard against this. Across the previous decades, we had a couple of successful diabetes prevention programs, and the diabetes prevention program is any act that takes place before the time of the diagnosis of diabetes in order to delay or completely prevent type 2 diabetes from happening. And the longest one in duration is the Daching diabetes prevention program and this has been published a couple of years ago, and it has shown that the blue line is the intervention arm, and it was just lifestyle intervention and exercise, including exercise and dietary control. The blue line is always here, the intervention arm, and the red line is the control arm. It's not only the diabetes prevention has succeeded to be lower with the intervention group, but it continued to be the same up to 30 years after the randomization. So a very minor courageous intervention at early phase of prediabetes might exert a positive outcome or favorable outcome up to 30 years after the intervention, according to Daching lifestyle intervention program. Not only diabetes, cardiovascular disease, cardiovascular death, and composite microvascular complications, they were all less prevalent in those who had an early intervention during their pre-diabetes phase and continued afterwards. The same has happened in the diabetes prevention program from the United States, somewhere between 15 to 30% reduction in the microvascular complications, including the placebo arm. Those placebo arms are still people living in the research or trial environment. They do receive a structural education, they do receive the standard of care, and they are being followed up. So there was a benefit even in the placebo arm, and there was a remarkable benefit in the lifestyle intervention arm, even more than the pharmacotherapy intervention arm. But the take-home message here was any modest intervention in prediabetes early on might even protect the heart and the kidneys at the long run. More recent data from the SELECT trial on the semaglutide, people living with obesity and prediabetes. And again, there was remarkable, almost 20% reduction in the cardiovascular outcomes, negative outcomes, and that was statistically significant. And those patients were not diabetic, only obesity and prediabetes phase. So lifestyle intervention, pharmacotherapy, have proven to protect the heart and the kidney when we had an intervention at the pre-diabetes phase, not waiting to the diabetes phase to take place. So just going quickly through the classical diabetes prevention programs, and the diabetes prevention program is either lifestyle intervention or lifestyle plus the pharmacotherapy intervention. And the lifestyle intervention, and this is an area where we need to have more of interaction and education and empowerment of all of us, healthcare providers, in order to deliver a more structured information to our beneficiaries, so to our patients. It includes the nutritional therapy, and we all know quite a lot about the nutritional therapy advice, physical exercise, whether it's aerobic exercise or resistance, or just to avoid sedentary life. And all of us are having an office work where we stay for 6 or 8 or 10 hours without even interrupting this by probably 5 or 10 minutes walk here and there. And this is a directly proportionate status with a future cardiovascular disease. Sleep disturbance, including the pathological sleep disturbance like obstructive sleep apnea and the circadian timing abnormalities. This is also an area where we need to focus and educate our patients about it. Stress and mental health is of paramount importance, though it's very demanding in terms of personnel and time, but we need to take care of it. Substance exposure, and here in the substance exposure, the ultra-processed food was considered as sort of a nutritional addiction that may end up with a negative cardiometabolic outcome. So this has to be taken care of in a therapeutic way to avoid it. And an area which has also almost always been overlooked, the social context, the equity, the food access, the cultural difficulties, and the work environment and others. So this needs a separate module by itself, and probably in future we might find more time to have a chat about it. Okay, so the diabetes prevention programs and different phases, different geographical regions in the world have managed to reduce the occurrence of type 2 diabetes by 50 to 60% without pharmacotherapy intervention. So just lifestyle, either nutritional support or nutritional advice in addition to exercise, have managed to reduce the occurrence of type 2 diabetes by almost 60%. And this was also durable for 15 years in the diabetes prevention program outcome study, where they followed those patients afterwards, and both intensive lifestyle group and the metformin managed to sustain less incidences of type 2 diabetes in those who had been randomized 15 years backwards. So the early intervention, whether it's lifestyle or pharmacotherapy, they both work, not only during the 4 or 5 or 9 years of the intervention, they do work way beyond that. And look ahead trial, probably all of you know about it, one of the largest lifestyle intervention trials to guard against type 2 diabetes. It managed to maintain almost 8% weight loss by the end of the first year. This has declined to 6% weight loss by the end of the study duration, which is around 9 years. So still many patients maintained a very reasonable weight reduction just by having a lifestyle intervention. And that was completely different from the standard of care, where it's 7% and only 3.5% weight reduction in the placebo arm. Okay, so the couple of years ago, we were discussing whether it's a delay of occurrence of type 2 diabetes or it's a treatment for the pre-diabetes phase. And when we had the nutritional therapy studies, and this is the direct trial, one of the most important, what's called the total dietary replacement studies, where they did randomize patients who were middle-aged with a newly diagnosed type 2 diabetes within 5 to 6 years, and they replaced their ordinary diet with 800 to 850 kilocalorie dietary formula. And that was only between 12 to 20 weeks. It wasn't for a year or 2 or 3, just 3 to 5 months of dietary intervention. And what they achieved is this data from the United Kingdom, almost half of the patients who were already diagnosed with type 2 diabetes for 5 or 6 years, in average, they achieved a complete remission of type 2 diabetes, not only control, not even just a tight control of type 2 diabetes. It's a complete remission of pharmacological intervention. So it was a cure of an early type 2 diabetes, an average of 6 years, moving them backwards to pre-diabetes or normoglycemia of treatment. And that was only through the lifestyle intervention. And the more it was directly proportionate, the more weight reduction, the more improvement, or the more data, positive data on the type 2 diabetes remission, reaching 86% remission of type 2 diabetes if patients did manage to reduce more than 15 kilograms of their total body weight. And even the 12-month follow-up and the 24-month follow-up, this has declined a little bit, but it's still almost a third of those patients maintained diabetes-free life records or health records. And this is very promising data. Yes, it's difficult to maintain the total dietary replacement, TDR, but it tells us that an aggressive intervention might lead to cure of type 2 diabetes. And we had similar data from Qatar, from our region, where we achieved 61% remission of type 2 diabetes in this cohort. And the probable reason is that they have chosen younger age group and the shorter duration of type 2 diabetes. It was 6 in direct trial, and it's around 3 years in the diadem trial in Qatar cohorts. But yet, total dietary replacement managed to reduce the occurrence of type 2 diabetes and regression of type 2 into either pre-diabetes or normoglycemia. And this is different scales of the direct trial. Up to 5 years, still almost 50% of the patients who achieved the complete remission maintained this remission up to 5 years. And it was much higher in diadem from Qatar, and we have another data also from the United Kingdom. Okay, so lifestyle intervention works, nutritional therapy works perfectly. What about the medical therapy? We all know about probably about metformin, pioglitazone, and the new kids in the plot, where the GLP-1 receptor agonist preparations have managed to reduce the pre-diabetes progression to type 2 diabetes remarkably. And for example, for semaglutide in step 1, step 3, and step 4, the people used to live with pre-diabetes, 84% to 89% of them reversed into normoglycemia, and they did not progress into type 2 diabetes during that trial period, and even after that for the follow-up with less percentages. But almost 90% of the patients who were expected to progress to type 2 diabetes maintained either pre-diabetes or reversed into normoglycemia. And data were almost the same from SURMOUNT trial, where they tested the tirzepatide in people with prediabetes. Again, 90% of them reversed the either normal glycemia or did not progress into type 2 diabetes, compared to only 13% did manage to the incidence of type 2 diabetes occurrence in the placebo arm was 13%, compared to only 1.3% of prediabetes progressed into type 2 diabetes. And this is almost 90% reduction rate compared to the placebo arm. Comparing the two GLP-1 preparations with a single agonist or dual agonist, and the data from this is the data from SURMOUNT-5, where we compared the tirzepatide with semaglutide head to head, and the data was almost comparable, especially in the HbA1c less than 6%. The difference was the prevention from progression to type 2 diabetes was 99% in people with on tirzepatide and 95% in people with semaglutide. Dropped a little bit when the HbA1c was less than 5.7, again 91% compared to 78%, and achieving two parameters of low HbA1c less than 5.7 and clearance of fasting plasma glucose into less than 100, achieved by almost 90% of the patients who lived with prediabetes in tirzepatide arm compared to 76%. And the take-home message from here that the pharmacotherapy intervention in prediabetes phase does a great and remarkable job. Almost majority of patients manage to revert from prediabetes to normal glycemia, and of course the lack of progression into type 2 diabetes. Comparing apples and pears, the still metformin lifestyle intervention, metformin plus lifestyle intervention, total dietary replacement, different data sets, and the GLP-1 receptor agonist preparations with a single agonist or dual agonist, they have remarkable outcome in prevention of type 2 diabetes. And of course, the most announced outcome was found in the GLP-1 receptor agonist therapy. Okay, so the last two slides will just go quickly through we've agreed now, or I hope now we are convinced that we have multiple tools to use to guard against prediabetes progression into type 2 diabetes, as well as regression into normal glycemia, including lifestyle intervention, including its 6 pillars, in addition to exercise, in addition to pharmacotherapy, which is a wide span of oral hypoglycemic agents up to the injectable forms of the relatively new medications of GLP receptor agonists. ADA have recommended us to the people who are they are in need to be treated in prediabetes. Those are the middle age category with a BMI more than 35, the fasting plasma glucose of more than 110, HbA1c equal or more than 6%, and any history of prior gestational diabetes, regardless the BMI, because the risk of progression to type 2 diabetes is quite high in a previous history of gestational diabetes, and many other situations where we need to treat type 2 pre-diabetes, either by lifestyle intervention or pharmacotherapy. But those are the patients that we need to include pharmacotherapy whenever we find one or more of those parameters. What we've done in our national guidelines here, and this has been touched upon in the previous two talks, that the Emirates Diabetes and Endocrine Society guidelines that published a couple of months ago, in the scenario of prediabetes, when the prediabetes is confirmed, we need to start with the intensive lifestyle intervention program for up to 3 months. And again, we repeat the fasting plasma glucose plus or minus OGTT or HbA1c and see the improvement. If there is improvement, then continue lifestyle intervention and repeat the test after another 3 months. And if it's still maintaining, then repeat the diagnostic test every 3 to 6 months and then monitor the patients. If the diabetes unfortunately developed, then you need to treat the patients as type 2 diabetes. If still in pre-diabetes phase, we'll continue in the pre-diabetes plan, which is intensive lifestyle intervention plus or minus pharmacotherapy. Okay, so if after the initial lifestyle intervention modification did not work in the first 3 months, so here we subcategorize the patients based on their weight. If they are living with obesity, then we consider the GLP receptor agonist or dual agonist GLP, GIP, or even SGLT2 inhibitors if the patient is having an established or high risk of atherosclerotic cardiovascular disease or CKD. And then we monitor them again. If the patient is not overweight or obese, then start with metformin or pioglitazone. So here, this is a very important discrimination that if a patient resistant to lifestyle intervention and he is living with obesity, then if we can afford the GLP-1s, the single or dual agonists or SGLT2 inhibitors, if it's indicated in terms of cardiorenal risk, then we do initiate the patients on that. If the patient is not living with obesity or no cardiovascular risk or established disease, then metformin is the first line therapy here, or the pioglitazone, and then we keep assessing after 3 months. If we fail to maintain the good glycemic parameters, then we can consider stronger medications here as well, even in absence of obesity and cardiovascular risk. We need to guard against the dysglycemia, especially if it is progressing forward. But if it is well controlled, then we'll go back again and monitor the patient every 3 to 6 months and waiting for good news of maintaining the pre-diabetes phase or even reversal of it and continuing the same plan, or the unfortunate update whether if the patient developed type 2 diabetes, then we go to the type 2 diabetes algorithm. I hope this summarizes the whole idea, and based on the evidence that I've shared with you earlier, now we have a good backup to introduce the newer medications, even in the era or the scenario of pre-diabetes plus or minus cardiovascular risk. And with that, I'd like to thank you very much and happy to take any questions and the Q&A session.
Thank you very much, Dr. Al-Amin. Another excellent presentation. It's my pleasure now to welcome Dr. Muhammad Hassanin. Dr. Muhammad is a consultant in endocrinology and professor of medicine, Muhammad bin Rashid University, and chair of diabetes and Ramadan Dar. Muhammad is going to talk about cardiovascular screening, the role of primary care physicians or role of primary care team. Dr. Muhammad, the floor is yours.
Thank you very much, Dr. Farghali. Great pleasure to be with you, Ala Al-Amin and Salah and everyone. So it's a great pleasure to be with you all. Let me just share my slides. Okay, I think you can all see my slides now. I'm conscious that we are 20 minutes later, so I'll try to be faster. So first of all, I've been asked to discuss the cardiovascular screening specifically from the perspective as if I am the primary care physician or the family medicine doctor. I have no conflict of interest for this presentation, and I cannot stress more upon the role of the primary care physician or the family medicine physician. I come from a background of NHS UK, where the vast majority of patients are seen by their family medicine or the primary care physicians. Indeed, when we develop the guidelines, we are conscious that 90% of people with type 2 diabetes and or other cardiovascular risk factors are seen in primary care. And primary care clinics are pretty busy. And the doctor needs to go through a complex number of issues within a short time scale. And at the end of the day, they are not like me, endocrinologists or diabetologists. They need to deal with following patients' psychiatric problem or obstetric problem or pediatrics. So their base knowledge is quite wide, and they need to address the needs of the person in front of them. And indeed, when we developed the guidelines and we published the cardiometabolic guidelines, we have listened today to beautiful presentations covering a number of guidelines that were produced by the EDS over the last 3 or 4 years, and focusing on the cardiometabolic aspect. Now, we need to remember what is the role of all of us, and indeed the guidelines. Of course, it needs to simplify and unify the process of identifying, managing, and preventing cardiovascular complications in people with diabetes. So it's very important, these 3 messages: simplify, unify the process of managing and prevention. That's really quite important. And of course, doing so, taking in mind the healthcare professionals, specifically the primary care physician, who are pretty busy and who need to focus on all of this. So this cartoon that we wrote, the patient is always in the center. And we are all, whether we're a primary care physician, an endocrinologist, ophthalmologist, nephrologist, cardiologist, you name it, we are all there to try to support the person with diabetes. And we just finished the session on the prevention of diabetes or reversal of diabetes. Indeed, for people with diabetes and even for cardiometabolic intervention, I cannot stress more the role of lifestyle, the choices of food and drink, the importance of physical activity to lose weight, and not just losing weight by the effect of the drug. Smoking cessation is an absolute key, and this is something that we are frequently not referring enough and not stressing it upon enough. The stress management as well as the sleep management. Nowadays, many people are on their iPad, their phone, and the sleep hours are becoming less and less, and consequently, they feel more and more stressed. So I want you here to look into the holistic approach. Of course, we need to address the statin, address the blood pressure, address the exercise, and address the diet, among many things. But look here into the value of smoking cessations. Absolute risk reduction is 9, which is the highest, and the absolute number needed to treat is the lowest, compared to all of the other points that I've just mentioned. So you guys in primary care, you are very able to address the smoking issues. And then moving on to the classical pillars of the management, the glycemia, the blood pressure, the lipids, and indeed the specific drugs. And the previous sessions have discussed many of these points. And I don't really need to repeat again what was being done about the role of SGLT2 inhibitors or the role of GLP or GLP-GIP receptor agonists in very well-structured randomized controlled trial for cardiovascular outcome. So our role, and as mentioned by Dr. Al-Amin, even pre-diabetes. So I'm a physician, come to me a person who looks like he has pre-diabetes, or indeed that person is type 2 diabetic or a type 1 diabetic for over 10 years, or an adult with type 1 that had been diagnosed recently. Any of these 3 categories, they need to be screened. Then how to screen them? Please remember the basics. Detailed history. Detailed history is very important. Our person with type 2 diabetes specifically will not come to us frequently with crushing chest pain or shortness of breath, or with classical signs of claudication. Of course, taking smoking history, as I just alluded, is very important. And then please make sure to examine your person with diabetes once a year at least, fully. Of course, if you've identified a problem that need further examination on more frequent basis, that's fine. And then the appropriate investigation, the HbA1c, the kidney function, the lipid profile, but don't forget the ECG and the proBNP, and don't forget the CBC. When you're doing the examination of the person with diabetes, don't forget to examine the foot with peripheral pulses, including ABI, as well as checking for peripheral neuropathy and the signs of peripheral neuropathy. So we agreed now that we're going to screen everyone with diabetes or pre-diabetes once a year. How we screen them? With a detailed history, with a full examination, including the pulses and the ABI and the retinal examination, and then we order the lab and the ECG that is required, including the pro-BNP, as well as the other classical ones. How frequent should we do that? Annually, unless the person is young and healthy and no problems whatsoever with pre-diabetes, then you can relax it to every 2 years. Now, who will be screened positive? That is the person who, on examination, you manage, for example, to identify that maybe the retina examination is abnormal, or maybe their peripheral pulse is abnormal, or perhaps the crackles on the lung, signs of heart failure, abnormal atrial heart rhythm, or abnormal ECG or pro-BNP, or renal function. So all of these are people who would be considered positive. What should I do with them? Now, number one, they are considered to be a very high-risk group. And this will be apparent more in your management. Of course, refer to the specific specialist. Why did they become very high risk? Oh, I detected retinopathy when I did the retinal camera or the fundoscope in my clinic. Then refer them to the ophthalmologist as well. And don't forget, again, I stress upon the lifestyle measures, including the smoking cessation, the weight management, and the increased physical activity. But many will be screen negative. Do we consider them as the low-risk people? No, of course not. We then need to look into their age, their duration of diabetes, and the presence of other classic cardiovascular risks, such as hypertension, smoking, obesity, or dyslipidemia. And accordingly, if the person, despite being score negative, but scores 4, then they are equally very high risk. If they score 3, they are at a high risk. If they score 2, they are at a moderate risk. If they score 1, they are low risk. Do these people exist? Yes, of course. We are diagnosing people as a teenagers with diabetes. They still didn't develop, perhaps not smokers, and perhaps didn't develop the hypertension and dyslipidemia or the complications yet. So young people, whether they are in their teens or their 20s or early 30s, do the systematic approach and diagnose them accordingly. And if you do this, you will be able to define what is my target for the glycemic control, how can I prevent the cardiovascular complications, how can I address the multifactorial intensive therapy, and certainly in red, I put it here, the timely referral to the appropriate specialist. So I'm just going to fly on this to just explain to you that every category would have different treatment for glycemia, for cardiovascular protection, for blood pressure, for LDL, and even for antiplatelet regulations. And don't forget the fine print. Don't forget that we need to think of SGLT2 as a preferred choice for heart failure or kidney problem, and GLP or GLP-GIP for atherosclerotic problems. But if contraindication is for one or intolerance for one, you can certainly use the other one. And certainly there is an indication for combining both when we are already started one and we are not achieving the target. Talking about targets, LDL target is very important. But if we cannot achieve it with a high-intensity statin, then we need to think of the other lipid-lowering agents. And if you achieve the LDL target, then don't forget the other lipids targets that need to be considered as well. So I have discussed briefly what should I do today if I see a patient in my clinic, but let me do it in a practical way as if this is a clinical case scenario. And trust me, this case is a very true case of someone who's pretty close to me. So I'm calling the patient Ahmed. His name is not Ahmed, but he was 56, works as a teacher, attends your busy clinic. He has diabetes diagnosed not long ago, 4 years ago. He's married. His HbA1c was 7. Previous HbA1c 4 months ago was 6.4. His current blood pressure today is 134/78. His LDL is 110. His ACR is normal and his eGFR is 88, which means that he's not in stage 3, he's stage 2. BMI is 31. And like many people in Gulf and Middle East in general, they have the social habit on when they go out once or twice a week, they smoke shisha. He did not do an ECG, and he's currently on metformin, which was started when he was first diagnosed, and now his HbA1c has moved from 6.4 to 7%. I want you, please, to focus on the case. I will leave it for a few seconds longer to digest the case again. A male of 56 years of age, diabetes for 4 years, HbA1c is 7, was 6.4, blood pressure figures is 134/78, LDL is 110, renal function is okay, BMI is 31, smoker, even though it's once or twice only per week, we don't have an ECG, and his metformin is on 1,000 milligrams per day. Now, I start to think of, why did his HbA1c over 4 months jump? Is he not taking the metformin, or has something changed in his lifestyle, or there is progression of the disease? That sometimes we see, although it's a significant jump over 4 months only. So I started to ask the person very well on his physical activity. And he said, I used to walk to the local mosque at Maghrib and at Isha and Fajr prayers on a daily basis. I frequently after Isha, would take a longer walk with one of my friends, chatting and making it as exercise. Now I pray at home. So I asked him, so why do you pray at home? He said, I've got leg pain. I went to see a doctor, and he did an X-ray for me, and he told me you have a calcaneal spur. So he went to see the specialist, and they injected him with a steroid injection. So maybe it's the steroid injection effect, maybe it's the lack of physical activity, because when I asked him further, has your pain settled? And he said no. So this is a very true case, and it's very frequent that we see in our practice. So the question then that would come to mind, should I re-refer him to the orthopedic surgeon for further treatment as his problem is not sorted, or should I start him on a non-steroidal or any other pain control? Or maybe this is just simply lack of fitness, and his glycemic control is only on 1 gram of metformin, and it's time to intensify the treatment. Should I actually do the above 3 points, or should I do something completely different than that? I'm not going to ask you to vote, but I want you to mentally vote and think of what would you do. And what I would personally say is, we need to go back to basics, as we said in the earlier part of the presentation. Systematic approach. Now, detailed history and examination, and then the appropriate investigations. Now, we've managed to get some history, but then we need a bit more history. And if you would have taken a bit more history from that person, as I did at the time, that person actually was my dad. And I asked him, where exactly is the pain? And it wasn't actually just in his ankle, it was more into his leg. So I did my examination, and part of the examination was to feel the pulses of the foot, which I couldn't feel on the same leg, of the left leg, that he had the problem. So he ended up with an angiogram and an angioplasty. So this is really quite important that we think of the systematic approach. Symptoms of claudication are mentioned very clear, but unless we start digging a bit more deep into the leg pain, perhaps we would say if the patient on statin, oh, this may be muscular pain because of the statin, or lack of fitness or whatever. That person, I've modified the case a bit. My dad was a regular cigarette smoker, not a shisha smoker, but he used to smoke over 20 cigarettes per day. And the investigation clearly showed peripheral arterial disease that required angioplasty. So don't forget that your patient with cardiovascular problem will not necessarily say, I have chest pain. They might complain of edema. They might complain of dizziness or palpitation. Fatigue or effort intolerance is sometimes a sign of cardiovascular problems. Syncope, and of course, the intermittent claudication and the angina are the classic ones that in people with diabetes, many are not doing. We've mentioned that we need to do the ABI. It's not a fancy test. It's simply the blood pressure on the of the person taking the right ankle blood pressure and dividing it up by the right arm blood pressure, and then repeating it on the left side as well to get the ratio, and then according to the ratio. If you train, if you can do it yourself, if you have the time, if you don't have the time, train one of your nurses to make sure that this becomes a routine. So you see, from a simple case of someone not known to be hypertensive, not known to be with hyperlipidemia, only diabetes for 4 years, HbA1c just got up to 7%. But from moving from perhaps a low or moderate risk category, then to a very high risk category, which then would dictate that you would need to think of all aspects. First to do, smoking cessation referral. Smoking here is the primarily risk factor for that person. Of course, thinking since the person have a vascular problem, then we need to think of an SGLT2 or a GLP-1 with evidence. We need to get the blood pressure under 130 and under 80 or even lower if you wish, using a RAS blockade. His LDL need to be under 55 using a high intensity statin. And if we're not able to achieve this, then combination therapy or other types of lipid lowering would be indicated. And certainly addressing the other parameters of physical activity, more ability to walk more, to train more, better diet, better salt in food, and certainly trying to consider the pros or cons of antiplatelets would be quite important. So you see, that person came just complaining and maybe thinking of, I have a calcanean spur and I have not too bad diabetes. Blood pressure, maybe we have blamed it for a bit of walking or whatever. Now that person needs a referral to smoking cessation clinic, needs a referral to vascular surgeon. We need to start him on a high intensity statin. We need to put him on a GLP-1 receptor agonist or a GLP-GIP with evidence as well, and or an SGLT2 inhibitor. We need to consider the suitability of aspirin in his case and give him an ACE or an angiotensin II antagonist, i.e. RAS blockade. So again, none of this is difficult for the primary care physician or the family medicine physician. We have fantastic service, and we have many, many able colleagues there who will be able to address this. So again, I put it in my presentation. Primary care physician or family medicine physician are one of the main cornerstones. Corner mean we have 4 corners usually. I don't know of a house with 3 corners. Perhaps we can have 5 or 6 or more, but certainly we need at least 4 corners, and primary care or family medicine are one of them. This is a photo from my beloved city, Alexandria. Thank you, and I'm happy to take any questions.
Thank you very much, Muhammad. Another excellent presentation. I would like to call for all speakers to open their camera and join the panel discussions. I just would like to start with the message which is given by all our speakers, that you have to start early and reach to the target as early as possible in treating your diabetic patient. I start with Al-Amin, who talk about the pre-diabetes and the importance of screening. And if you look to our guidelines, the first one published in 2020, second one updated in 2026, you can say that we keep the age of screening starting from the age of 30 because of the GCC cardiovascular trial shows that our patient in this area, they got diabetes, cardiovascular disease 10 years younger than the European and the American. That's why we would like to start as early as possible to detect cases. Then I go to Salah and he talk about the early intervention, and even when you start treatment of your diabetic patient at the time of diagnosis, are we really delayed? And he proved that because of the errors of metabolism of hyperglycemia, which started 4 to 11 years or 12 years before the date of diagnosis, and the qualitative and the quantitative reduction in the functioning beta cells. Then Ala talked nicely about the clinical inertia and the importance of step up in management if you are not on target. Then if you look to the diabetes, the main cause of death in 63% of diabetic patient is cardiovascular disease. Even patient with chronic kidney disease, they die because of cardiovascular disease. So the message is clear from all our speakers. Now I start with Alamin again. Alamin, my question to you, if you have a pre-diabetic patient, metformin is cornerstone in management for all pre-diabetic or only selective cases of pre-diabetic?
Thank you very much, Professor Farghali. This is an important and practical question. And the prevalence of prediabetes is almost 20% of the populations that we're taking care of. So we all should be empowered about this category of patients that we see. As the Emirates Diabetes and Endocrine Society guidelines and many other international society recommendations, that the higher the glycemic indices, where the HbA1c equals or more than 6%, fasting plasma glucose equal or more than 110, or any previous history of gestational diabetes, obesity in middle age group, and anyone who's on long-term obesogenic and diabetogenic medications. Those are the vulnerable group that to progress into type 2 diabetes faster and getting the negative outcomes probably faster as well. Therefore, the recommendation for this category, they should be on pharmacotherapy as well. Metformin is the usual first-line therapy. However, we have nicely detailed that if a person living with obesity and with established cardiorenal disease or at high risk of cardiorenal disease, then we would rather choose a medication that tackles the prediabetes and tackles cardiorenal risk as well. And here would be the GLP-1 single or dual agonist or the SGLT2 inhibitors. If this is not the case, then metformin is the usual first-line therapy in this category of patients.
You show in your presentation that GLP-1 receptor agonist or GLP-GIP can work very well in pre-diabetic. We know that from the FDA approval of medication that they approve metformin and pioglitazone in case of treatment of pre-diabetic. Any room now for GLP-GIP to be used in pre-diabetic patients?
Yes, Professor. Now they are licensed to be in diabetic or people living with diabetes and those not living with diabetes, either pre-diabetes or just simple obesity. with a high risk of cardiorenal disease or established disease. So if the patient is having pre-diabetes plus, then those medications are licensed and approved by the regulatory bodies to be on board. If not this scenario, then the classic and old is gold, as Professor Hassan always say, metformin and pioglitazone would take care of the simple dysglycemia.
We hope, Dr. Farghali, sorry for the interruption,
Go
is
ahead.
that would be feasible, because in many cases you would like to prescribe these drugs, the GLP and the GIP, in the absence of diabetes, but in high cardiorenal risk with pre-diabetes. But unfortunately, insurance stop us, or authorities, even without insurance, even in authorities that are not looking into the insurance, such as in my previous hospital, we are not allowed to prescribe them for non-diabetics.
Yeah.
So it would really be important that we try to lobby for the benefit of preventing the problem, because the cost of the disease itself is much higher than the cost of the prevention.
Agreed 100%. Alaa, you talk about a very sensitive topic related to clinical inertia. And the inertia always, sometimes both sides, whether clinical inertia from the treating physician or from patients. We have a study run to the GPs in US about the clinical inertia in initiating insulin for their patients. And when this study comes from the both public and the physicians, it shows that it is 85% in physicians versus only 15% in the patient side, because they scared of hypoglycemia in both sides, but it is more in physician sides rather than patient sides. Your comment?
I absolutely agree, Professor Farghali. The issue with physicians, usually they believe that if we talk to the patient and we tell them that we are going to start these medications, patients likely are going to refuse. And the second part from the physician side is the worry about hypoglycemia and risk of hypoglycemia. We're lucky enough right now, as I mentioned earlier, that we have medications that can intensively control diabetes without the risk of hypoglycemia. All recent medications does not cause hypoglycemia. Now, even the frequency, if there is a worry about the frequency of injections, even the injections now, instead of 4 times a day, it's once in a week. And I guess all these together should vanish the worries of physicians with regard to, if I intensify it, I might be causing more harm. So physicians should be rested. From our side, we should work more on educating physicians on intensive glycemic control and the benefits of intensive glycemic control. I believe if I sit and I talk to my patient and I explain to him the benefits that they are going to get out of the whatever medicine, name it insulin or other than insulin, I don't think any of the patients is going to refuse. The idea is educate physicians to educate their patients to accept the treatment as well.
Mohammed, I think the cardiometabolic guideline is one of the best guidelines which we developed for Emirates. I think all of us were member in the development of these guidelines, and the calculator, which you worked hard on that with Dr. Hani Sabur and the team. It's really, really very nice to have our own calculator in United Arab Emirates. But I'm not sure whether all physicians are aware of this calculator to be used for assessing cardiovascular disease in our area or no. If you comment on that, Mohammed.
You are very right, Dr. Farghali. I have been recently in some meetings, and when you review the recent guidelines, they have started to come to our targets. and to come to some of our recommendations that people used to be uncertain about, the age, the duration, the pro-BNB, and so forth. So it's really a good quality. However, the challenge for any guidelines is the implementation. And without tools for implementation and without the power to audit and to award people who are, and to perhaps do the opposite for people who are not, it's really quite important. Whether I'm talking about family medicine, primary care, secondary care, tertiary care, we should be all addressing the problems in the same fashion. The patients get confused. If one patient come to the three of us and each one of us have a different approach, then that will be very confusing. What's the value of the guidelines if we don't implement them? Then it becomes just a document on a folder or on the shelf as they used to be in the past. So implementation with tools, and you have championed, Dr. Farghari, for primary care and for the private sector, some very nice initiatives that incentivize people if they would to achieve the targets. And that's really quite important, using our local guidelines that have been developed by experts from in the field, from in all, and not just the cardiometabolic, the nephropathy, the retinopathy, the type 2, the obesity. All of these excellent guidelines have been developed over the last few years, need to be implemented both by the healthcare professionals and adopted and agreed upon by the insurance as well as the health authority, including the governmental ones.
Thank you, Mohammed. Open question, any taker as you like. Any study support delay beta cell apoptosis by using pioglitazone?
Apoptosis, I'm not sure, but pioglitazone is one of the drugs, and actually TZDs were one of the drugs that were used with evidence in the prevention of diabetes. They also have a role in MASLD, and many people with metabolic syndrome, insulin resistance, would have that problem as well. It's well established. The only advice is don't go to the high doses so that you benefit from the quality of the drug without maximizing the side effects. What is the thoughts of Ala and Amin? I'm not sure.
I'm not sure about any studies with pioglitazone, but I'm aware that with incretin-based therapy, the early studies, there were some data that showed incretin-based therapy do preserve the beta cells in the early studies, but I'm not sure about apoptosis specifically with pioglitazone.
I agree with both, and probably indirectly we can extrapolate from the preservation of beta cell function. That's indirect delay of beta cell apoptosis in early type 2 diabetes. Equally, no idea about the previous data on lab-wise beta cell preservation.
Another open question, what if a patient with pre-diabetes has low eGFR? Is that an early indicator of nephropathy?
As
Okay.
Dr. Salah mentioned, sorry, Lamin, carry on.
Please.
Yeah, as Dr. Salah mentioned, sometimes the complications, we do see complications even earlier at the time of dysglycemia and before development of diabetes. So patients might develop proteinuria or microalbuminuria early on. And I think by then, if we don't intensify lifestyle, diet, as well as probably if it did not disappear, start them on ACE inhibitors and SGLT2 inhibitors, then we'll be very late if we wait until they develop diabetes.
I mean, this is quite an important question, Dr. Farghali, and what Ala mentioned is absolutely right. The impairment in renal function is not just because of glycemia, perhaps many other factors. And also, the evidence nowadays for the SGLT2 inhibitors in halting the progression is in diabetics and in non-diabetics as well. So that's why in our guidelines, we have said treat the pre-diabetics and utilize the same methods of therapy.
Thank you. Last question we have from the audience. First, thank you for the excellent webinar. Screening in pre-diabetes is next to impossible. This question for me, I will answer it, by the way, is next to impossible with the insurance companies. How can we get through that? Please advise. I think since 5 years, we put screening for diabetes is one of the screening criteria to be covered by insurance. So when we developed the PASMA program for screening for 3 types of cancer, we add to it diabetes. Diabetes should be screened free of charge, covered by insurance, and the policy, they put it every 2 years. If you didn't do any screening for diabetes, you can do it as long as the gap is 2 years. So it is your right to request, and it is not the right of insurance to reject. It is already there. Anybody would like to add any comment, anything from our speakers?
Well, I guess we can, I mean, if my patients are complaining of symptoms, then the test will be justified.
Yeah.
My patients complaining of polyuria or thirst, then screening for diabetes will be justified.
When we set the law for insurance, we set for example, for the basic benefit plan or blue collars, they renew their visa every 2 years, and at that time they are eligible to do screening for diabetes as part of the screening, and it is free of charge. Thank you very much. We learned a lot from all of you today. Thank you for our audience for attending this session and this module today. I would like to thank Dr. Salah Abu Snana, Muhammad Hassanin, Al-Amin, and Dr. Alaa. Thank you very much for your input and insight in presenting tonight. Thank you, Lily, for supporting these modules. And thank you, MCI, for organizing such a beautiful organization. Summer School of Diabetes will continue, Module 3, weight as a clinical imperative from risk factor to treatment target. It will be in 28th of July, 8 p.m. to 10 p.m. Thank you very much for all, and have a good night. Thank you.
Thank you for the smooth moderation, Dr. Farghari.
Thank you.
Thank you very much. Have a good night, all of you.
Thank you.
Thank you.
Assalamu alaikum.
Wassalam. Thank you.